ओके गाइस, तो इस वीडियो में हम बात करेंगे एक गेस्ट पेपर सीरीज मीन्स कुछ ऐसे क्वेश्चंस जिनके एग्जाम में आने के चांस, क्वेश्चन तो नहीं आते एग्जैक्टली लेकिन टॉपिक्स वही रहते हैं। तो यहाँ पर हम 20-25 वो इम्पोर्टेंट टॉपिक्स को फोकस करेंगे जो पेपर में जनरली आते आते हैं। तो मैंने इन क्वेश्चंस को सिलेक्ट किया था पिछले 5 साल का पेपर देखकर और पिछले 1 साल का इंडिया में जितने भी एग्जाम है उनका पेपर देख के जो क्वेश्चन सिमिलर टॉपिक होते हैं उसको डिस्कस करते हैं अभी। सो विदाउट वेस्टिंग मच ऑफ योर टाइम, देखो अनीमिया से एक क्वेश्चन पेपर में आता है तो हम इसको पढ़ते हैं। 30-year-old फीमेल, 30 साल की फीमेल है। फर्स्ट हिंट इन द MCQ इज ऑलवेज एज। फीमेल है, ऑन स्ट्रिक्ट वेजिटेरियन डाइट। अब ये एक इजी क्वेश्चन है जो कई लोगों को आंसर पता है लेकिन कुछ बच्चों से इजी में गलती हो जाती है एग्जाम के प्रेशर में। तो प्रेजेंटेड फटीग, पैलर, हीमोग्लोबिन 9 है, MCV 110। सो क्लियर कट आप देख सकते हो, इट्स अ केस ऑफ मैक्रोसाइटिक अनीमिया। तो ये पेशेंट को क्या है, मैक्रोसाइटिक अनीमिया। So it's a case of macrocytic anemia. So macrocytic, or I can use the term megaloblastic. So megaloblastic anemia तो generally I can say vegetarian diet दिया हुआ है तो more likely chance it is a B12 deficiency. तो ये B12 की deficiency है तो iron deficiency microcytic होता है, sideroblastic microcytic होता है, sickle cell anemia normocytic होता है। तो आंसर will become B. तो ऐसा ही आपको एक क्वेश्चन एग्जाम में मिलेगा तो उसको कैसे सॉल्व करना है एक बार उसको देखते हैं। तो सबसे पहले आपको देखना है अनीमिया के क्वेश्चन में हीमोग्लोबिन ऑफ कोर्स कम दिया होगा। सो हम ये मानते हैं कि क्लिनिकल केस होगा, हीमोग्लोबिन विल बी गिवन एज लो। तो उसके बाद जो आपको अगला पैरामीटर चेक करना है दैट इज MCV। तो MCV की नॉर्मल वैल्यू जो होती है दैट इज 80 to 100 फेंटोलीटर। अब इस MCV के बिहाफ पे वी कैन डिवाइड अनीमिया। सो अगर MCV की वैल्यू 80 से कम है इसको हम बोलेंगे माइक्रोसाइटिक। अगर 80 to 100 के बीच में है नॉर्मोसाइटिक, और मोर देन 100 मैक्रोसाइटिक। सो जस्ट याद रखिए कि माइक्रोसाइटिक हाइपोक्रोमिक अनीमिया मीन दिस इज व्हेन MCV वैल्यू इज लेस देन 80, तो इसको हम बोलते हैं माइक्रोसाइटिक हाइपोक्रोमिक। ये हो गया नॉर्मोसाइटिक नॉर्मोक्रोमिक एंड दिस इज मैक्रोसाइटिक। तो ये मैं आपको बार बार बोल रहा हूँ बिकॉज यहाँ से क्वेश्चन आता ही आता है। तो इफ यू सी मैक्रोसाइटिक मीन्स यहाँ पर आपको याद रखना है B12 डेफिशिएंसी, फॉलेट डेफिशिएंसी। तो B12 डेफिशिएंसी का अगर क्वेश्चन होगा तो आप देखोगे कि वहाँ पर वेजिटेरियन डाइट लिखा होगा। फॉलेट में जनरली प्रेगनेंसी की हिस्ट्री होगी या फिर कोई ड्रग्स जैसे कि मीथोट्रेक्सेट, फेनिटोइन। अगर नॉर्मोसाइटिक की बात करूँ तो जितने भी हीमोलाइटिक अनीमिया है जहाँ पर हीमोलाइसिस होता है वो नॉर्मोसाइटिक में आएंगे। दूसरा आपको याद रखना है CKD का अनीमिया जो होता है और ए प्लास्टिक अनीमिया। CKD का अनीमिया और ए प्लास्टिक अनीमिया ये सब किस में आएंगे, नॉर्मोसाइटिक में। अब इन दोनों की बात करूँ तो यहाँ पर देखो बॉडी में RBC प्रोड्यूस नहीं हो रही तो इन दोनों के अंदर रेटिकुलोसाइट काउंट भी कम रहेगा। हीमोलाइसिस में RBC की डेथ हो रही है तो जब बेबी RBC होंगी बढ़ेंगी तो रेटिकुलोसाइट काउंट बढ़ा हुआ आएगा। माइक्रोसाइटिक हाइपोक्रोमिक आपको याद रखना है विद निमोनिक शीतल। शीतल का मतलब होता है S इज सिडरोब्लास्टिक, तो S विल बी सिडरोब्लास्टिक। I is IDA, iron deficiency. T is thalassemia. A is AOCD. L is lead poisoning। और lead poisoning बेसिकली कुछ अलग से नहीं है, lead poisoning इज अ टाइप ऑफ सिडरोब्लास्टिक अनीमिया। जस्ट मैं दो चीज़ों पे यहाँ पे हाईलाइट करूँगा कि थैलेसीमिया इन लेटर स्टेजेस, थैलेसीमिया में आगे जाके कई बार ज़्यादा हीमोलाइसिस होना चालू हो जाता है, देन थैलेसीमिया कैन बिकम नॉर्मोसाइटिक। सिमिलरली अनीमिया ऑफ क्रोनिक डिसीज ये भी लेटर स्टेज में जाके किस में कन्वर्ट हो जाएगा, नॉर्मोसाइटिक नॉर्मोक्रोमिक में। तो यहाँ से मैं एक्सपेक्ट कर रहा हूँ एक क्वेश्चन एग्जाम में। सो दिस इज लाइक माय लिस्ट ऑफ एक्सपेक्टेड क्वेश्चन नंबर 1। आगे चलते हैं, यहाँ से आपको सॉल्व करना है क्वेश्चन इस तरीके से। कमिंग टू क्वेश्चन नंबर 2, अ 13-year-old पेशेंट। अगेन पहली हिंट आपको देखो, बड़े क्वेश्चन होते हैं, मेडिसिन के क्लिनिकल केस होते हैं तो आपको बार बार पढ़ोगे टाइम नहीं मिलेगा। स्मोकी यूरिन, स्मोकी यूरिन से अगर आपको कुछ समझ में ना तो यहाँ देखो डिस्मॉर्फिक आरबीसी का शेप अलग अलग आ रहा है। मोर देन 20 हाई पावर फील्ड, WBC भी है 2 से 4। अब देखो WBC सिर्फ 2 से 4 है तो ये सिग्निफिकेंट नहीं है। फिर अगर आप देखोगे यहाँ पर क्वेश्चन में स्मोकी यूरिन आ रहा है, आरबीसी टूट रही है, इसका मतलब पेशेंट को हेमाचूरिया तो हो रहा है, हेमाचूरिया तो हो रहा है। हेमाचूरिया का अगर मैं आपको बात करूँ मोस्ट कॉमन कोज, तो वो होता है आपका स्टोन। अब यहाँ पे ब्लैडर कैलकुलाई में स्टोन दिया हुआ है, ब्लैडर में स्टोन है, तो ऐसा हो सकता है, तो उसको मैं प्रोबेबल आंसर रखता हूँ। यूटीआई में जनरली हेमाचूरिया नहीं होता, बर्निंग मैचुरेशन होती है। सो डिस्मॉर्फिक आरबीसीज अगर आ रही हैं तो हेमाचूरिया हो रहा है। अब एमसीडी और पीएसजीएन की बात करूं तो एमसीडी इज अ टाइप ऑफ नेफ्रोटिक सिंड्रोम। ऑफ नेफ्रोटिक सिंड्रोम में जो मेन फीचर होता है दैट इज लिपिडूरिया। तो इसमें पेशेंट को आपको क्या दिखेगा, फोमी यूरिन, यूरिन में झाग आएगी, लिपिड्स आएंगे, लिपिड की कास्ट मिलेंगी। तो एमसीडी इज नेफ्रोटिक, ये रूल्ड आउट हो रहा है। सो हेमाचूरिया की अगर मैं बात करूं तो आपको दो चीजें दिमाग में रखनी है प्रैक्टिस में। तो मोस्ट कॉमन कॉज स्टोन, स्टोन या तो वो किडनी में हो या ब्लैडर में हो, मीन स्टोन और कैलकुलाई। लेकिन इसके अलावा हेमाचूरिया का जो आपको याद रखना है एमसीक्यू पॉइंट ऑफ व्यू से, हमेशा ग्लोमेरुलोनेफ्राइटिस के क्वेश्चन में भी हेमाचूरिया होता है। और ग्लोमेरुलोनेफ्राइटिस दो तरीके की होती है, नेफ्रोटिक सिंड्रोम और नेफ्राइटिक सिंड्रोम। तो याद रखो मेरी बात, नेफ्राइटिक सिंड्रोम में हेमाचूरिया होता है। अब हमारे पास दो ऑप्शन रूल आउट हो गया, बचता है पीएसजीएन। पीएसजीएन इज अ टाइप ऑफ नेफ्राइटिक सिंड्रोम या ब्लैडर कैलकुलाई। सो इसको याद करने के लिए एक मैं रूल आपको बता रहा हूँ, दैट इज कॉल्ड 40:5:1 रूल। अगर आपकी बॉडी में 40% और मोर डिस्मॉर्फिक आरबीसी है, 40% और मोर डिस्मॉर्फिक आरबीसी, 5% और मोर acanthocytes, and even one single RBC cast, तो इन तीनों में से कोई भी एक चीज है तो हम ये मानते हैं कि जो हेमाचूरिया है दैट इज ग्लोमेरुलर इन ओरिजिन। अब इसको देखिए कि 13 साल के बच्चे में स्टोन की प्रोबेबिलिटी थोड़ी कम होती है। दूसरा यहाँ पे स्मोकी यूरिन, तो स्मोकी यूरिन दिया हुआ है, तो इसके जो दूसरे सिनोनिम होते हैं वो कोला कलर यूरिन, आइस टी कलर यूरिन, स्मोकी यूरिन। अब कोला कलर से आपको आंसर मिल गया, दैट इज पीएसजीएन। तो याद रखिए जब ये कॉज दिया है इट मीन्स हेमाचूरिया इज ड्यू टू ग्लोमेरुलोनेफ्राइटिस। सो जस्ट इन सिंपल लैंग्वेज आई कैन से, अगर किसी पेशेंट को स्टोन की वजह से हेमाचूरिया हो रहा है तो आरबीसी की शेप होगी वो स्टोन की वजह से एक साथ आरबीसी एक ही शेप की कटेंगे, इसको बोलते हैं आइसोमॉर्फिक आरबीसी। तो यू विल सी आइसोमॉर्फिक आरबीसी। और अगर ग्लोमेरुलोनेफ्राइटिस की वजह से हो रहा है, नेफ्राइटिक सिंड्रोम की वजह से हो रहा है, तब आपको क्या मिलेगी, डिस्मॉर्फिक आरबीसी। तो ये आपको दो चीजें याद रखनी है। फिर एग्जाम में एक क्वेश्चन पूछते हैं कि जितनी ये ग्लोमेरुलोनेफ्राइटिस है इनका क्वेश्चन को कैसे सॉल्व करना है। तो जस्ट मैं आपको बता रहा हूँ कि कुछ ग्लोमेरुलोनेफ्राइटिस नेफ्राइटिक सिंड्रोम होती है, तो मैं शॉर्ट में देता हूँ नेफ्राइटिक सिंड्रोम। और कुछ ग्लोमेरुलोनेफ्राइटिस में नेफ्रोटिक सिंड्रोम। तो क्लासिकल फीचर आपको याद रखना है, नेफ्राइटिक सिंड्रोम के अंदर पेशेंट को हेमाचूरिया मिलेगा और नेफ्रोटिक सिंड्रोम के अंदर जो क्लासिकल फीचर मिलता है दैट इज प्रोटीनूरिया। कुछ डिसीज ऐसी भी होती हैं जिनमें आपको दोनों के फीचर मिलेंगे, दोनों के मीन्स पेशेंट को नेफ्राइटिक भी होगा नेफ्रोटिक भी होगा। तो अब इसको समझते हैं। नेफ्राइटिक सिंड्रोम, नेफ्राइटिक सिंड्रोम जो आपको मिलेगा उसको याद करने का एक निमोनिक में दे रहा हूँ, उसका नाम होता है परी। P फॉर PSGN, पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस। ए से दो चीजें यहाँ पर, अल्पर्ट सिंड्रोम, और ए से एंटी जीबीएम। एंटी जीबीएम का मतलब होता है एंटी ग्लोमेरुलर बेसमेंट मेम्ब्रेन। एंटी जीबीएम को हम गुड पास्चर सिंड्रोम भी बोलते हैं। एंटी जीबीएम इज ऑल्सो कॉल्ड एज गुड पास्चर सिंड्रोम। आर स्टैंड फॉर आरपीजीएन, आरपीजीएन। और आई का मतलब होगा यहाँ आईजीए नेफ्रोपैथी, आईजीए नेफ्रोपैथी। आईजीए नेफ्रोपैथी को हम बोलते हैं बर्जर्स डिसीज, बर्जर्स डिसीज। तो ये मैंने जो 5 डिसीज लिखी मैं लेबलिंग भी कर दे रहा हूँ बिकॉज निमोनिक में चार पीए आ रही है तो आपको 4 लगेगा, लेकिन 5 है, 1 2 3 4 5। ये आपको याद रखना, दीज आर प्राइमरली नेफ्राइटिक। नेफ्रोटिक की बात करूं तो यहाँ पर आपको 3 डिसीज याद रखनी है विच आर वेरी वेरी इंपॉर्टेंट. द मोस्ट इंपॉर्टेंट इज MCD, मिनिमल चेंज डिसीज. फिर जो हमारे पास आता है MGN, मेम्ब्रेनस ग्लोमेरुलोनेफ्राइटिस, एंड थर्ड इज फोकल सेगमेंटल ग्लोमेरुलोस्क्लेरोसिस, FSGS. तो कई बार क्वेश्चन आता है कि ऑल एक्सेप्ट फैशन में ऑल आर नेफ्रोटिक सिंड्रोम एक्सेप्ट, ऑल आर नेफ्रोटिक एक्सेप्ट. और याद रखिए 2 डिसीज आपको याद रखने जिनमें दोनों के फीचर होंगे. एक होता है MPGN, मेम्ब्रेनो प्रोलिफरेटिव ग्लोमेरुलोनेफ्राइटिस, और दूसरा होता है DPGN. DPGN कुछ नहीं है, SLE नेफ्राइटिस के 6 टाइप होते हैं. तो टाइप 1, 2, 3 में उतने सिम्टम नहीं होते, और टाइप 4 में पेशेंट को सबसे ज़्यादा सिम्टम होते हैं, तभी पेशेंट डॉक्टर के पास आता है. तो टाइप 4 का ही डायग्नोस होता है प्रैक्टिस में. और टाइप 5 एंड 6 दीज आर एडवांस डिसीज. सो टाइप 4 इज मोस्ट कॉमन टाइप डायग्नोस्ड. और टाइप 4 SLE नेफ्राइटिस को हम क्या बोलते हैं? DPGN. और याद रखिए डिस्मॉर्फिक RBC इज अ क्लासिकल फीचर ऑफ ग्लोमेरुलर डैमेज, मींस ग्लोमेरुलोनेफ्राइटिस. वो स्टोर में नहीं मिलेगा. मूविंग टू नेक्स्ट क्वेश्चन. अगेन दिस इज वेरी वेरी इंपॉर्टेंट. ये तो आप पिछले 5 साल का रिकॉर्ड देख लो, यहाँ से क्वेश्चन आते हैं एग्जाम में. सो फीमेल पेशेंट्स हैविंग फीवर फॉर पास्ट 3 days एंड कैन नॉट टच नेक टू चेस्ट. इसका मतलब क्या है? आप देखोगे नेक रिजिडिटी है, LP वॉज डन, लंबर पंक्चर हुआ, CSF फाइंडिंग्स आर. तो आप देखोगे CSF की स्टडी से हमेशा क्वेश्चन आता है एग्जाम में. तो CSF में आपको बेसिकली क्या क्या देखना होता है? आपको पेशेंट का ओपनिंग प्रेशर देखना है, ओपनिंग प्रेशर. देन वी हैव टू सी प्रोटीन्स. CSF में कितनी प्रोटीन्स है. उसके बाद आपको CSF का ग्लूकोज देखना है, ग्लूकोज देखना है. CSF का कलर देख लो, और नेचर देख लो कि वो टर्बिड है या नॉर्मल क्लियर है, वाटर जैसा है, या थोड़ा उसमें गाढ़ापन आ गया, विस्कोसिटी बढ़ गई है. तो इन सारे सारे पैरामीटर्स पे आपको बात करनी है. अब जनरली जो एग्जाम में क्वेश्चन आता है आपके पास 3 डिफरेंशियल होते हैं, और ये बहुत इजी क्वेश्चन होता है. पता नहीं इससे इतना क्यों डर लगता है लोगों को. देखो आपको एग्जाम में या तो बैक्टीरियल मेनिंजाइटिस पूछते हैं, और याद रखना बैक्टीरिया के जैसी फंगस होती है. फंगस मेनिंजाइटिस आर वेरी रेयर. तो जनरली पेशेंट को हिस्ट्री होगी इम्यूनो कॉम्प्रोमाइजेशन की. तो क्वेश्चन जो आपको एग्जाम में मिलता है बैक्टीरिया, और दे कैन आस्क यू क्वेश्चन ऑन माइकोबैक्टीरिया मींस ट्यूबरकुलर. टीबी भी बैक्टीरिया है लेकिन थोड़ा सा अलग है. और तीसरा वायरल. अब बैक्टीरिया में पस बनती है, तो बैक्टीरियल मेनिंजाइटिस को हम पायोजेनिक भी बोलते हैं, और वायरल मेनिंजाइटिस को हम एसेप्टिक बोलते हैं. सो वी कॉल दिस एसेप्टिक. नाउ अंडरस्टैंड ओपनिंग प्रेशर. CSF ओपनिंग प्रेशर प्रोटीन्स ये हर मेनिंजाइटिस के अंदर बढ़ेगी. तो मैं यहाँ बस एरो लगा रहा हूँ. याद रखो मेरा स्टेटमेंट, ओपनिंग प्रेशर एंड प्रोटीन्स विल इंक्रीज इन ऑल मेनिंजाइटिस. सब में बढ़ गई. अब याद रखो कि अगर बैक्टीरिया है तो कुछ कलर हो भी सकता है, या नॉर्मल कलर, जैसे कुछ बैक्टीरिया पिगमेंट जिनके पास होता है दे विल गिव सम कलर. और जब प्रोटीन बढ़ रही है तो आप देखोगे थोड़ा सा प्रोटीन बढ़ रहा है, कुछ ना कुछ पिगमेंट्स आ रहे हैं, तो नेचर थोड़ा सा टर्बिड हो जाएगा. मीन्स यू विल सी अ थिक CSF. टीबी बैक्टीरिया में अगेन या तो ये स्ट्रॉ कलर का होगा, हो सकता है, लेकिन ये वाटरी भी रहे, मीन्स क्लियर रहे, लेकिन थिक तो हो जाएगा. लेकिन वायरल का कलर भी क्लियर होता है पानी के जैसा, और नेचर भी क्लियर होता है. So again, take home messages. If you see bacterial meningitis, TB is also bacteria. So there will be, I can say there may some color. Only those bacteria who have the color, who have some pigment, they will provide some color. But it will be thick. Viral, it is not thick. It is clear. Now remember, bacteria love sugar, and this is the biggest hint in the MCQ. So normally in CF we have 2/3 of blood glucose. तो हमारी बॉडी में जो ग्लूकोज है उसका 2/3 किसमें? CSF में. सो बैक्टीरिया लव ग्लूकोज, दे विल ईट ऑल द ग्लूकोज. तो CSF में आप देखोगे मींस बैक्टीरियल मेनिंजाइटिस के अंदर ग्लूकोज कम होगा, बिकॉज बैक्टीरिया सारे शुगर को खा जाएंगे. सो दिस विल डिक्रीज. टीबी बैक्टीरिया, इन वायरल इट विल बी नॉर्मल. तो याद रखो, विद दिस इन माइंड वी विल सी द क्वेश्चन नाउ एंड ट्राई टू आंसर दिस. अब देखो अपीयरेंस कैसा है, वाइट क्लाउडी, तो यहाँ से कुछ हिंट नहीं मिल रही है। सेल्स में न्यूट्रोफिल्स, ओके वन मोर थिंग, जस्ट अगर सेल्स की बात करूँ तो याद रखो, अगर बैक्टीरियल मेनिंजाइटिस है, बैक्टीरिया मीन्स जनरली दे ट्रिगर एन acute inflammation, so main cells will be polymorphoneutrophils. TB bacteria, but this will trigger a chronic inflammation, so here main cells in tubercular, main cells will be PMN, and main cells will be lymphocytes, and in viral also main cells will be lymphocytes. ये आपको याद रखना है। अब यहाँ पर जब दे दिया है न्यूट्रोफिल्स, आगे देखते हैं CSF शुगर इज 15। तो एक इंसान की बॉडी में अगर मैं बात करूँ, सपोज मेरा ब्लड शुगर 100 से 120 के बीच में रहेगा, इफ़ आई एम नॉन डायबिटिक, तो ये मेरे ब्लड शुगर होगा, दिस विल बी माई ब्लड शुगर, सो माई CSF शुगर विल बी 2/3 ऑफ दिस। अगर आप इसका 2/3 निकालोगे, 100 का 2/3 विल बी 66.66, सो इट इज़ इन द रेंज ऑफ 60 to 80। तो CSF में नॉर्मल लोगों में, नॉन डायबिटिक लोगों में 60 to 80 मिलीग्राम पर डेसीलीटर शुगर होता है। अब यहाँ पर देखो CSF शुगर कम हो गया, तो शुगर कम हो गया, प्रोटीन को देखना ही नहीं है, प्रोटीन तो किसी में भी बढ़ता है, सब में बढ़ता है। अब देखो शुगर कम है और न्यूट्रोफिल्स है, तो फंगल मेनिंजाइटिस में हिस्ट्री होनी चाहिए, इम्यूनो कॉम्प्रोमाइजेशन की, वो हिस्ट्री नहीं दे रखी। वायरल में ग्लूकोज कैसा रहेगा, वायरल में ग्लूकोज विल बी नॉर्मल, यहाँ पर ग्लूकोज कम है। अब बचा टीबी और बैक्टीरिया। टीबी में लिम्फोसाइट्स होंगे, न्यूट्रोफिल्स किसमें होगा, न्यूट्रोफिल्स विल बी इन बैक्टीरियल। अब कुछ लोग बोलते हैं कि टीबी में हमने पढ़ा था कॉब वेब CSF, तो उसके हिसाब से वाइट क्लाउडी CSF को कॉब वेब बोलते हैं, तो टीबी आंसर होना चाहिए। लेकिन देखो टीबी में सेल्स कैसे होंगे, लिम्फोसाइट्स। देयर आर सम अदर बैक्टीरिया ऑल्सो, वहाँ पर भी वाइट क्लाउडी आ सकता है, इज क्लियर। तो वहाँ पर भी वाइट क्लाउड हो सकता है, तो ऐसा आपको नहीं दे सोचना है कि सिर्फ वन लाइनर रट के आंसर नहीं करना है, सारे पैरामीटर्स आपको पढ़ने हैं। कुछ बैक्टीरिया के पास कोई पिगमेंट नहीं होगा, तो वहाँ पर भी आपको क्लाउडी CSF मिलेगा। हर बैक्टीरियल मेनिंजाइटिस के अंदर CSF में कलर नहीं आता। इनफैक्ट जब आप प्रैक्टिस करोगे आप देखोगे ये कलर का कोई कॉन्सेप्ट होता ही नहीं है, तो कलर को आपको ध्यान नहीं देना है। हम जो बोलते हैं प्रैक्टिस में सूडोमोनास का ग्रीन कलर, मैंने आज तक कभी ग्रीन कलर का CSF आते हुए नहीं देखा, क्लियर। तो इस आपको समझना है कि CSF जनरली क्लियर ही होता है, और इट कैन बी विस्कस, इट कैन बी क्लाउडी, बट कलर आपको जनरली देखने को नहीं मिलता है। तो न्यूट्रोफिल्स हैं, शुगर कम हो रही है, तो मोर चांस इट इज बैक्टीरियल मेनिंजाइटिस। तो ये एक टेबल मैं चाहता हूँ एक बार आप हाथ से बनाओ, पक्का यहाँ से क्वेश्चन आना है। ओके, तो आगे चलते हैं। फॉलोइंग ड्रग इज बेस्ट फॉर यूरेट लोवरिंग थेरेपी इन ट्यूमर लाइसिस सिंड्रोम। अब इसको देखो, अगर आप यहाँ ऑप्शन देखोगे, एलोप्रिनोल, फेबुक्सोस्टैट, फिरोसेमाइड, रास्बुरिकेस, ये सारे के सारे ड्रग यूरिक एसिड को कम करते हैं। सो ऑल दीज आर यूरेट लोवरिंग ड्रग्स। तो यूरेट लोवरिंग ड्रग्स, तो बेसिकली ये फार्माकोलॉजी मेडिसिन का ओवरलैप MCQ है। फिरोसेमाइड एक डायूरेटिक होती है। तो पहले जस्ट मैं यहाँ कुछ बताना चाह रहा हूँ ट्यूमर लाइसिस सिंड्रोम के बारे में। अगर किसी ट्यूमर का ब्रेकडाउन हुआ, किसी की कीमो चल रही है या रेडियोथेरेपी चल रही है, so with CT or RT tumor cells will break down and this will lead to electrolyte imbalance। so electrolyte imbalance जो आपको याद रखना है कि पेशेंट का कैल्शियम कम हो जाएगा, लेकिन बाकी सब बढ़ जाएगा, बाकी सारे इलेक्ट्रोलाइट बढ़ेंगे। मीन्स देयर विल बी हाइपरनेट्रीमिया, हाइपरकैलेमिया, हाइपरयूरिसीमिया। अब यूरिक एसिड बढ़ रहा है, तो उसको कैसे कंट्रोल करोगे? सो जनरली यूरिक एसिड कम करने के लिए हम क्या देते हैं, ज़ैंथिन ऑक्सीडेज इनहिबिटर। सो ज़ैंथिन ऑक्सीडेज इनहिबिटर हमारे पास यहाँ पर ये दोनों हैं। ये दोनों गाउट में तो अच्छा इफेक्टिव होते हैं, बट याद रखिए ये इसमें काम नहीं करेंगे। फिर अगर बात करूँ फिरोसेमाइड की, अगर आप पेशेंट को डायूरेटिक यहाँ पर देते हो, तो देखो पहले से पेशेंट को कैल्शियम कम है पेशेंट का, और फिरोसेमाइड इस लूप डायूरेटिक, इसको देने के बाद कैल्शियम और कम हो जाएगा, कैल्शियम विल बी फर्दर लो, इसलिए इसको नहीं दोगे। सो जस्ट रिमेंबर रास्ब्यूरिकेस, बर्ड्स के अंदर एक एंजाइम होता है यूरिकेस, उस रिकॉम्बिनेंट DNA टेक्नोलॉजी से ड्रग बनता है। सो वी हैव वन मोर ड्रग रास्ब्यूरिकेस, वन मोर इज पेग्लोटिकेस। So these drugs are a little bit expensive. So we use these two drugs. One, either when patient is having refractory gout, रिफ्रैक्टरी गाउट मीन्स आपने पेशेंट को सब चला लिया, फिर भी उसका गाउट ठीक नहीं हो रहा, यूरिक एसिड कम नहीं हो रहा। सेकेंड इज वी यूज दिस ड्रग इन ट्यूमर लाइसिस सिंड्रोम। अगर किसी पेशेंट को हाइपर यूरिसीमिया है ड्यू टू ट्यूमर लाइसिस सिंड्रोम, इन दैट केस यू विल यूज रास्पबेरी केस। तो ये आपको याद रखना है। मूविंग टू नेक्स्ट एमसीक्यू, दैट इज अ क्रोनिक लिवर डिसीज पेशेंट प्रेजेंटेड एट ओपीडी। तो सीएलडी का पेशेंट है, तो सीएलडी का पेशेंट है तो आपको ऑटोमेटिक दिमाग में समझ जाओ कि इस पेशेंट को एसाइटिस तो हो गई होगा। तो मोस्ट पेशेंट विद सीएलडी विल हैव एसाइटिस, पेट में पानी भरा हुआ है। आगे दे दिया एसाइटिक फ्लूइड एग्जामिनेशन रिवील्ड न्यूट्रोफिल्स 500 पर माइक्रोलीटर। अगर आप एसाइटिक फ्लूइड का एग्जामिनेशन करोगे तो जनरली आप देखोगे, अब पेट में पानी भरा हुआ तो आप पेशेंट को डायरेटिक देते हो। एसाइटिक फ्लूइड व्हेनेवर यू आर चेकिंग, तो एसाइटिक फ्लूइड में हम बेसिकली क्या चेक करते हैं, तो हम सैंपल को भेजते हैं, द सैंपल वी चेक द सैंपल, वी सेंड द सैंपल फॉर एसाइटिक फ्लूइड में आपको क्या क्या देखना है, आपको देखना है पेशेंट के सेल्स, वी चेक फॉर एटिपिकल सेल्स। सो ये सेल्स नॉर्मल सेल्स मीन्स न्यूट्रोफिल्स है, डब्ल्यूबीसी कितने हैं, तो ये सैंपल पैथोलॉजी लैब में जाएगा। फिर ये एसाइटिक फ्लूइड का एक सैंपल बायोकेमिस्ट्री लैब में जाएगा जहाँ पर हम प्रोटीन देखते हैं। प्रोटीन में आपको एसाइटिक फ्लूइड की एल्बुमिन देखनी है, और जब आपके पास एल्बुमिन आ गई तो आप साग रेशियो निकालोगे। आपके पास जो एलएफटी रिपोर्ट होगी, इन एलएफटी रिपोर्ट यू विल हैव सीरम एल्बुमिन, serum albumin minus ascitic fluid albumin, that difference is called SAG, serum ascites albumin gradient. So this sample will be going to biochemistry lab, this will be going into pathology lab, this is going into path lab, this will go to biochem lab. We will also send the sample for glucose. So again this will go into biochem lab. Then third sample we are sending this to microbiology lab for culture. कल्चर के लिए और क्या करोगे आप, देन यू कैन ऑल्सो सी लाइक ग्रोथ ऑफ सम बैक्टीरिया, कल्चर पता चल जाएगा आपको। दिस विल बी गो वेयर, दिस विल गोइंग इनटू माइक्रो लैब। अब यहाँ पर दिया हुआ है कि पेशेंट के न्यूट्रोफिल्स बढ़े हुए हैं, इसका मतलब कोई ना कोई बैक्टीरिया का इन्फेक्शन है। सो इसको एक कंडीशन होती है, इसको हम बोलते हैं स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस, एसबीपी। तो एसबीपी को कैसे डायग्नोज करोगे, व्हेन यू विल सी इन एसाइटिक फ्लूइड सैंपल इफ न्यूट्रोफिल्स, इफ आई कैन से डब्ल्यूबीसी, अगर आप देखोगे टोटल डब्ल्यूबीसीज दीज आर मोर देन 500, एंड आउट ऑफ दिस इफ न्यूट्रोफिल्स, अगर इसमें से भी अगर न्यूट्रोफिल्स काउंट आर मोर देन 250, तो अंडरस्टैंड दिस, यहाँ पर ऑलरेडी दिया हुआ है कि न्यूट्रोफिल्स 500 से ज़्यादा है, दिस इज वेरी वेरी इंपॉर्टेंट। मैंने आपको बताया टोटल डब्ल्यूबीसी शुड बी मोर देन 500 पर माइक्रोलीटर, एंड आउट ऑफ दिस अगर सिर्फ न्यूट्रोफिल्स 500 ज़्यादा ऑलरेडी दे रखी हैं, लेकिन हमको तो 250 चाहिए थी, देन दिस इज हाउ वी मेक अ डायग्नोसिस ऑफ स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस। इसका मतलब स्पॉन्टेनियस मीन्स ऑल ऑफ अ सडन, बैक्टीरियल पेरिटोनाइटिस, अब जो पानी भरा हुआ है, दैट फ्लूइड इज अकोमोडेटेड इन एब्डोमिनल कैविटी, दैट फ्लूइड is very dangerous, this can lead to death of the patient. So in this case how you will manage, in this case we will give injection of cefotaxime, or we can use injection of ceftriaxone. So drug of choice will be cephalosporins. Now this patient should not develop this again. So for prophylaxis we give norfloxacin. For prophylaxis we give norfloxacin. तो अगेन दिस क्वेश्चन ऑलरेडी केम, सो आई एम एक्सपेक्टिंग कि इस बार आपसे ये पूछ लें, तो दिस विल बी एक्सपेक्टेड क्वेश्चन, नॉरफ्लॉक्सासिन, व्हिच ड्रग वी यूज फॉर प्रोफाइलैक्सिस ऑफ स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस। अगले क्वेश्चन पे चलते हैं। तो अगेन दिस इज फेवरेट टॉपिक, बार बार एग्जाम में पूछते हैं लाइक व्हाट आर वेरियस मार्कर्स। तो आप देखोगे यहाँ पे एचबीएस एंटीजन नेगेटिव, एंटी एचबीएस एंटीबॉडी नेगेटिव, एंटी एचबीसी एंटीबॉडी नेगेटिव, एंटी एचबीई नेगेटिव, सब कुछ तो नेगेटिव है, एक ये पॉजिटिव, एंटी एचबीएस एंटीबॉडी पॉजिटिव। So again this type of question they ask in exam, so just I want to tell you some markers, look at the screen। मार्कर्स याद करने का तरीका होता है CE CES, SCECES means HBS antigen. Hepatitis B surface antigen. Suppose if this marker is positive, अगर ये positive है, then this is telling you like there is entry of the virus. HBC antigen positive. अब जनरली ये पॉजिटिव होता ही नहीं, बिकॉज दिस इज लाइक कोर, वायरस का कोर, वायरस इज इन नैनोमीटर, उसका भी कोर, सो दिस इज नॉट डिटेक्टेड. सो एक ही एमसीक्यू आपसे पूछ सकते हैं विच इज नॉट डिटेक्टेड इन लैबोरेटरी. अगर डिटेक्ट हो भी किया, दैट विल नॉट मेक सिग्निफिकेंट इम्पैक्ट ऑन योर एमसीक्यू एंड योर प्रैक्टिस. देन वी हैव HBE एंटीजन. नाउ दिस HBE एंटीजन, the virus which entered your body, that virus is now replicating, dividing. So this is a marker of infectivity, means virus when it is replicating or when it is dividing, it means viral load is more. More viral load means, again, more viral load means that infection will now turn to be infective. Then we have antibody, anti-HBC antibody. This antibody will be of two types. It can be IgM or it can be IgG. If it is IgM, it means acute infection. And if it is IgG, it is a chronic infection. So how we write this? IgM anti-HBC antibody, IgG anti-HBC antibody. Then we have anti-HBE antibody. So suppose if this is positive, acute, this is positive, chronic. HBE antigen was telling you about infectivity. Now, if you develop antibody against it, that means it is no longer infective. It is no longer infective. It is no more infective. And anti-HBS antibody positive. It means the virus who entered your body, now it is totally cured. But if only this is positive, it means that is telling you status of vaccinated. So let us see the question now. Look at the screen carefully. HBS antigen negative. जब ये negative है, it means there is no entry. There is no entry of virus. Anti-HBS antibody negative. ये भी negative है. Anti-HBC antibody positive means this is positive. This is given positive. This is something given positive. Anti-HB, बाकी सब negative है. So understand, sometime what happens, there is a period called window period. So window period में क्या होता है, like IgM is very fast. IgM is very fast in your body. Like IgM can turn positive before surface antigen to turn positive. So this phase is called window period. Clear? तो आपको याद रखना है, यहाँ पर क्वेश्चन को ध्यान से देखना है, लाइक एंटी HBC एंटीबॉडी पॉजिटिव, सो इट वुड बी IgM IgG. सो दिस पीरियड इज व्हाट वी कॉल दिस विंडो पीरियड. बाकी सब नेगेटिव दिए हैं. सो जस्ट ट्राई टू अंडरस्टैंड दिस. और किस तरीके से क्वेश्चन पूछते हैं, जस्ट लेट मी ट्राई टू कंफ्यूज यू अ लिटिल सो दैट यू कैन गेट एन आइडिया व्हाट टाइप ऑफ क्वेश्चन दे आस्क इन एग्जाम. सो दे विल गिव यू सम ऑफ दिस मार्कर्स एज पॉजिटिव. सपोज ये पॉजिटिव दे दिया, पॉजिटिव पॉजिटिव पॉजिटिव. तो यू कैन सी हियर एंट्री हो गई, डिवाइड कर रहा है, इन्फेक्टिव, IgM पॉजिटिव, एक्यूट. इट इज एक्यूट इन्फेक्टिव हेपेटाइटिस बी. Suppose if I write like this, this will be chronic infective hepatitis B. Chronic non-infective. अगर मैं इसको पॉजिटिव कर दूं तो chronic infective. Suppose if I do this positive, this will become chronic. Now it is non-infective. Suppose if I write like this, this will be acute non-infective hepatitis B. And ultimately, suppose if nothing is positive or only this is positive, so there is no entry, virus की entry नहीं हुई. This is called vaccinated. And if I say this is positive, so this is the patient cured. ये ठीक हो गया. Now understand, sometimes they can ask you like IgM anti-HBC is positive. So this phase is called window period. because after a few days you will see HBS antigen will turn positive. So this is very very important. बार बार एग्जाम में आपसे पूछते हैं like markers of hepatitis B. Moving to next one, in patient with dialysis dementia, what is deposited in cerebral cortex? So first they are asking you dialysis dementia. So many of you can confuse कि dialysis word दे दिया, तो we think it could be like A beta 2M type of, but they're asking what is amyloid deposit in cortex, brain में कौन सी होगी? So brain में तो A beta होती है. A beta 2M is seen in kidney. Amyloid transthyretin, it is seen in heart, right? So answer is A beta. I think it's repeated twice. So A beta amyloid. So again they ask you one question on amyloid. Let us see this amyloid. So we have A L type of amyloid, A type of amyloid, A beta 2M, A beta, ATTR, IAP, IAPP. Then what we have? IAP. So then understand this thing. Now what type of question they ask? One more I can say ACAL. So let us see. AL means amyloid light chain. So AL amyloid is also called as primary amyloid. Primary amyloid is seen in a patient of multiple myeloma. तो ये आपको याद रखना है, 1 MCQ in exam. AA is called secondary amyloid. Secondary amyloid is seen in a patient with chronic inflammation. ये chronic inflammation में होगी. Or sometimes you can see AA type of amyloidosis you can see in a rare condition called familial Mediterranean fever. So जितनी भी chronic inflammation, like in India the most common cause is TB, but in world it is rheumatoid arthritis. So जितनी भी like ulcerative colitis, Crohn disease, chronic inflammation. A type, expected question. A beta 2M, A beta 2M, it is seen in kidney. So in dialysis patient, but in kidney. In CKD patient, in kidney, right? A beta is amyloidosis, amyloid of your brain. So CNS amyloid. So basically क्या होगा in Alzheimer disease patient. यहाँ पर अगर आपसे पूछते they can mention you CKD patient or patient like who is recipient of kidney transplant or patient on dialysis. अब देखो क्वेश्चन में यहाँ कंफ्यूज क्या किया है, डायलिसिस पेशेंट दे दिया है, तो वी थॉट इट कुड बी A beta 2M, but they're asking you what is deposited in cortex. In cortex what we have A beta. ATTR is amyloid transthyretin, so it is seen in heart. So in a patient of restrictive cardiomyopathy. ATTR sometimes you can see it is deposited in few conditions like we call this familial amyloidotic polyneuropathy, right? And sometimes you can see in condition ये FAB वो नहीं है, familial adenomatous polyposis नहीं है, familial amyloidotic polyneuropathy and senile systemic amyloidosis. IAPP, islet associated pancreatic polypeptide. So it is something, pancreatic means it's an amyloidosis of pancreas. And where you will see this? You will see this in a patient of diabetes. Then isolated atrial amyloid. This is like also an amyloid which we see in atria, in heart. But remember, it is an amyloid that we see only and only where? In atria. So ये atria में होगा, ventricles में नहीं होगा. This is seen in the atria, not in the ventricle. So we call this isolated atrial amyloid. So it can be in right atria, left atria. ACAL is an amyloid. CAL stands for calcitonin. Calcitonin is released from parafollicular cells of your thyroid gland. So वहाँ का जो ट्यूमर होता है उसको बोलते हैं MTC, medullary thyroid carcinoma. So this is again a list of amyloid which you have to remember. One question in exam, very very important. Exam से पहले पढ़ने इसको एक बार. Moving to next one. अब देखो ये मैंने इसलिए डाल दिया, I know many of you are knowing this answer, but again ये बार बार पिछले 3 साल से पूछ रहे हैं, तो I'm expecting like this could be again a question on this. A known patient with type 1 diabetes presented with finding of DK. RBS is 400, ketones are 3 positive. So DK का diagnose बनाने के लिए, to make a diagnosis of DK, you will have D for diabetic range blood sugar. So basically diabetic range तो मैंने लिख दिया, but blood sugar is mostly in the range of 300 to 600 milligram per deciliter. K for ketosis means if you see ketone bodies should be positive. A for acidosis. A for acidosis means you will see pH. pH कैसा होगा? Acidic pH होगा. So pH will be less. In this question, you can see, let us see how many things are needed to make a diagnosis. We need all three. We need all three. But again, question में तो mention ही कर दिया ना, like patient is having findings of decay. Then they have mentioned like patient is having ketones are 3 positive. So following is most appropriate in management. So let us see. Start infusion of insulin immediately. In decay, remember primary goal of treatment. So decay में सबसे पहले आपको क्या करना है? We have to flush these ketone bodies with fluid. So always remember, infusion of insulin immediately, no. Give subcutaneous insulin, no. Instead of subcutaneous, what we'll prefer? We'll prefer IV. आपको IV देना है, but because bioavailability of IV drug is 100%. A fluid bolus followed by insulin infusion, this is correct. पहले आपको fluid देना है. No insulin needed, no. We have to give insulin. So just remember the stepwise management of a decay. Just I'm writing this because बार-बार बच्चे गलती करते हैं कि नहीं इंसुलिन दे दो पहले. इंसुलिन तो देना ही है. So first and the most priority is we have to give fluid. Fluid, what fluid we give? We can give NS. So we are using a normal saline. So this is the fluid of choice, NS. When you are using NS, normal saline, when we are giving, so initially we give like a huge, we give a lot of fluid. We give fast bolus. After NS, what we give? We give regular insulin. Regular insulin. So आपको NS के bolus देने. Then regular insulin we give in a dose of 0.1 mg per kg. 0.1 mg per kg stat. IV. So suppose if my weight is 80 kg, so you have to give me 80 into 0.1, that is 8 units. So आपको वो IV उतना ही dose देना है. Then what we do? We continue normal saline followed by half normal saline. Half normal saline को क्या बोलता है? N/2 plus insulin. So this we continue IV fluid, we continue insulin, and this insulin like we give continue with infusion pump. Then insulin can cause potassium deficiency. Then we can add KCl. We can give KCl, and if you do the ABG analysis, suppose if patient pH is very low, in that case we can add soda bicarb. Otherwise, generally in most cases, remember soda bicarb is not needed if you timely manage the patient. So these are the things, stepwise manner is very, very important, because in exam they are asking you question, but they are asking you like stepwise approach. IV fluid insulin, IV fluid, then regular insulin, then we continue insulin. Again, this insulin will also be same, regular. Remember, there is no role of subcutaneous insulin here. Unless patient is achieving or regaining his appetite, he is improving. KCl, soda bicarb. So this is like how you have to manage a patient. And as soon as patient regain appetite, he is stable, he is conscious, he is talking, he is alert, then we can switch to subcutaneous insulin, right? So that is the approach which you have to remember. So route of choice will be IV, not subcutaneous. Now only one insulin we have, that is IV, that is regular insulin. So sometime in exam they ask you lente we can give, no, we have to use regular insulin. So this is important, stepwise management. So you have to remember these 5 points. That's it. It's very, very important. Moving to next one, a 37-year-old female complaint of weakness. Young female, weakness, pallor of hand. Pallor of hand means anemia. She also mentioned difficulty while having food. Difficulty while having food means there is some sort of dysphagia. Is the following suits probable diagnosis for this lady? What do you think? So can thyroid disorders can have anemia? Rarely. Thyroid diseases can cause macrocytic anemia. Sometimes it can be normocytic anemia. Can myasthenia gravis? Again, very rarely. If it could be peripheral neuropathy, it could be due to B12 deficiency, right? But dysphagia is not seen. In thyroid disease also, like we'll see dysphagia unlikely. So again, we have to decode this question, understand this Patterson-Kelly syndrome. The full name is Patterson-Brown-Kelly syndrome. We also call this Plummer-Vinson syndrome. So in Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome, what we see, patient will have iron deficiency anemia. There will be glossitis. There will be post-cricoid esophageal webs, and because of these webs, patient will develop dysphagia. And it's a condition which is more in females. So frankly telling you, I have never seen a patient of this disease. It's a rare disease, but it's very common in MCQ. So Plummer-Wilson syndrome. Now let us see what are the hints given here. Female. So again, you can see here female. Then you can see pallor. So pallor means why pallor? Because of iron deficiency anemia. Then it is the biggest hint in the MCQ, like dysphagia. Dysphagia will occur because of webs. So sometimes they ask you the feature, sometimes they ask you this is a triad, and this is more in females. So remember Plummer-Wilson syndrome or Patterson-Brown-Kelly syndrome, iron deficiency anemia, there will be glossitis. Now you will tell me, sir, glossitis is not given. Let it be, but other things are matching, right? Esophageal webs, and that can cause dysphagia, and it is more in females. Moving to next one. Again, you can see this question came in exam, so they sometimes ask you a question on MI, and they want you to locate the territory of MI. So if you see the ECG, you can see lead 2 clear cut. Then if I want to tell you, you can see this in lead 3 also. So classical ST elevation. Then where else I can notice? I can notice ST elevation in AVF. So lead 2, 3 AVF. So 2, 3 AVF, if you see ST elevation, it's the classical case of inferior wall MI, right? So just remember, whenever they ask you, suppose if they have given changes in V1, V2. If they have mentioned changes in lead V1 and V2, it means septal arteries are involved. V2, V3, V4. This is suggesting of anterior wall MI, which is most common MI. V5, V6. Lateral wall MI. Lead 2, lead 3, AVF. Inferior wall MI. And sometime if you see the changes in V7, V8, V9, in this case it is posterior wall MI. So these are like additional leads. So remember this because you have to see the territory of MI, and MI ECG is pretty easy in exam. So you can notice here. Moving to next one, that is a 36-year-old woman present with ulceration over her finger. Ulceration over her fingers. She also has history of Raynaud phenomena and GERD since 3 years. Following can be used as a screening test. This is like a bit complicated question now. Try to understand this. First, you tell me what is the diagnosis. So if you see diagnosis of this disease, patients having GERD and Raynaud phenomena. So what's the condition where we can see Raynaud phenomena? When it comes to Raynaud phenomena, it could be like idiopathic, it could be cold climate, or it could be due to, I can say, emotional drive. Sometimes people can develop Raynaud, but here they have mentioned GERD for a reason. So there is a syndrome called CREST syndrome. CREST stands for calcinosis, Raynaud, esophageal dysmotility. That's why she is having GERD. Sclerodactyly means if you see these fingers are having these folds will be absent. Then what we have telangiectasia. So in this I have two hints, means there is Raynaud phenomena, there is esophageal dysmotility that is leading to GERD. CREST syndrome is seen where we see this in scleroderma. So scleroderma we have different type, like systemic form called systemic sclerosis, and localized version is called CREST syndrome. So understand this CREST scleroderma, how we screen this. So now even though you know the question, you know the diagnosis, still many of you are thinking to mark the answer, like the antibody which is specific for CREST syndrome is anti-centromere. But they're not asking you specific, they're asking you antibody for screening. So mark my word, for screening, what antibody we have ANA. I know here you made a mistake, but this mistake should not be repeated in exam. So understand this, whenever we assume or a case of scleroderma, first test what you will do, we will do ANA. If ANA turned to be positive, then we check for specific antibody, and that is going to be, suppose if we are suspecting CREST syndrome, in that case it will be anticentromere. If it is a systemic form, then we will check for anti-topoisomerase. This is for systemic sclerosis, again specific antibody. Anticentromere, specific antibody for CREST syndrome. Anticardiolipin we see in APLA syndrome. So that is again for screening. Question is for screening. So screening, what we have ANA, remember. So ANA is screening test in rheumatology, very, very important. So then we think about specific antibody. Clear? So I hope the question is a bit clear. It was a bit complicated. Okay guys, so अगले question पे चलते हैं. So we have a patient presented with right-sided hemiparesis that completely resolved in 6 hours. So again, this is the hint in the MCQ, like a patient is having hemiparesis which is resolving in less than 24 hours. So clear-cut diagnosis with this will be TIA. So it is a case of transient ischemic attack. So remember, for TIA, to define TIA, remember the time limit is 24 hours. So if a person who is having stroke-like presentation and there is a complete resolution in less than 24 hours, we call that TIA. And most TIA, they will resolve in less than 1 hour. Now, what score will you use to determine the risk of future stroke in this patient? So remember, understand this, we have discussed in the class also. For like any TIA patient, if you want to predict future chances of stroke, and we have to start them antiplatelet or I can say anticoagulant. In that case, we use a score. That score is ABCD2 score. ABCD2 score. So understand this. ABCD2 score meaning is age of the patient. So higher the age, higher is the chance of stroke. So if age is more than 60 years, we say like we give 1 point. Then B stands for BP. If patient BP is high, then again like patient hypertensive, that will give, then we will give 1 point. C stands for clinical features. So in clinical features, we have 2 things, like either my patient is coming to you with hemiparesis. So I can say unilateral hemiparesis, or my patient is coming with sudden loss of speech or speech impairment. So for higher age, we give 1 point. For hypertension, we give 1 point. For hemiparesis, we give 2 points. For speech loss, or I can say speech impairment. Now understand, if duration, D stands for duration. So duration, if it is less than 10 minutes, then we give nothing, we give score of 0. If it is in the range of 10 to 59 minutes, we give 1 point. And if it is more than 1 hour or more than 60 minutes, then we give 2 points. So higher the score, higher will be the chance of stroke in future. So you have to remember ABCD2 score. Okay, to tell you about these other things, CHATS S2 VAS score. This is a score. This is like we use to initiate, I can say, antiplatelet drug, or I can say anticoagulant drug in a patient who is having atrial fibrillation. So remember, CHATS VAS score. It is to use embolus prophylaxis in atrial fibrillation. So in a patient having atrial fibrillation, there is a chance like he or she can develop, I can say, emboli, and to prevent that emboli, what we are giving antiplatelet and anticoagulant. Curve 65 score, it is to assess the severity of pneumonia. It is to assess severity of pneumonia. And based on this score, we have to decide like it's a case of pneumonia, whether to admit this patient and where to admit this patient. Means suppose if score value is less, then we can simply discharge the patient. So treatment will be OPD basis. So you can start a macrolide or beta-lactam and tell the patient to take these medications for 5 to 7 days. If score value is more, then we need to decide, is it an ICU admission or it is a non-ICU simple ward admission. ABC2 we have discussed. Apache 2 score is used to assess severity in acute pancreatitis. So to assess the severity in pancreatitis, what we have Apache 2 score. So these are some scores which you have to remember. Coming to next MCQ, you can see a 33-year-old woman. So first hint in the MCQ is 33-year-old. So this is like a topic which is I am seeing from past 1.5 years, this is a question which is coming in almost every exam. So if you see, like if I talk about FMG last exam, then I can talk about INICET, NEET PG. So in past year, in last means 2022 was loaded with this same topic, same question again and again. So just many of the students, what they do a mistake, like whenever they see this type of question, 33-year-old woman with excessive daytime sleepiness, BMI is more, BP is high, partial pressure of oxygen 70, PCO2 53, bicarbonate 33. What is the most likely diagnosis? So most people, we think it's a case of obstructive sleep apnea. We call this OSA. So let me just tell you this thing. Cushing syndrome, there is no other thing. So patient having only respiratory complaint. Cushing syndrome patient will have more complaint. So Cushing syndrome patient, they may also have sleeping difficulties, but they will also have some other features, like there will be like thin skin, a centripetal obesity or central abdominal obesity. We call this lemon on stick appearance, thin limbs, osteoporosis, pre-diabetes or diabetes. So there will be many features in Cushing. So that's why it's ruled out. Now we have obstructive sleep apnea and central sleep apnea. So obstructive sleep apnea, here you will see like patient will have episodes of apnea and hypopnea. We call this AHI index. But I remember if patient is having features of like it could be the answer. So I can say I'm putting a dot here. Central sleep apnea, the problem will be in your brain. So understand this thing here. You can see like patient is obese. Obstructive sleep apnea, central sleep apnea, problem is not the obesity, it is a problem in the brain. So we are left with two options, obesity, hypoventilation syndrome and obstructive sleep apnea. So how we differentiate these two syndrome, remember? In obstructive hypoventilation syndrome, you can notice like patient BMI will always be more than 30. So patient is always obese, first thing. Then you can see patient will always be in a state of respiratory acidosis. Patient will always be in a state of respiratory acidosis. So these two things are present here. But if you see obstructive sleep apnea, sometime like I have seen few patients which are not obese, but they can develop OSA. So remember, these two are not, obesity can cause OSA, but obesity is not a mandatory feature to be, or we wish to confirm OSA. So that is why the more correct answer for this question will be obesity hypoventilation syndrome. Why? Because reason number one, you can see patient BMI is more, so it is clear cut telling you about obesity. And if you look at the PCO2 value is normal 35 to 45, it's 53. So patient is in a state of respiratory acidosis. So both two things it is satisfying. So that's why it's a case of respiratory acidosis. This is a case of obesity hypoventilation syndrome. So remember, this is one of the very important topic that they ask in exam. Moving to next one, which is the following is best confirmatory test to diagnose thalassemia trait. So remember, thalassemia trait is something which is very common in Sindhis, Punjabis community and some Muslim communities. Even I can say like people living near to Bagha border, some part of India, some part of Pakistan. In that area, it's very common, especially in like in India, talk about Himachal Pradesh, Punjab. So thalassemia trait means patient will not have much symptom, right? Family history is there. So how you will confirm? So basically they are asking you what is best test to diagnose thalassemia. Simple. To confirm. So remember, for thalassemia means whenever there is a hemoglobin chain defect, so best test is HPLC. HPLC stands for high performance liquid chromatography. But sometimes it is not given in the option. So next best choice for this will be hemoglobin electrophoresis. So next best test will be hemoglobin electrophoresis. So just try to understand this thing. HPLC is the best test, followed by electrophoresis. Now you can see peripheral smear. In peripheral smear of thalassemia, you will see these type of cells. These type of cells we call them target cells. Sometimes you can see this type of cell we call them teardrop cell. So again, but target cells you can see in many other conditions. Similarly, teardrop cells you can also see in myelofibrosis. So peripheral smear, mark my word, it is never a confirmatory test for any disease. So peripheral smear means it is nothing. It is like you are making a smear and pathologist seeing the smear under microscope. So it is never the investigation of choice. Now coming to next test, which is naked eye single tube, so RBC osmotic fragility test. So let me just see this again. Naked eye single tube RBC osmotic fragility test. It is a test, we use this for screening of thalassemia. For thalassemia screening, we can use this. But again, it is not for confirmatory, so that is unlikely the answer. Now, reticulocytosis means increase in reticulocyte count. So, reticulocyte count can be increased in many conditions. So, it can increase in any hemolytic anemia. So, again, reticulocytosis will never be confirmatory for any anemia. Now, we are left with elevated HbA2. So, in hemoglobin electrophoresis, what we do? We see the level of hemoglobin A, we see the level of hemoglobin A2, and we see the level of hemoglobin F. So, this is how we confirm hemoglobin A, A2, hemoglobin F. So ultimately, they have not given hemoglobin electrophoresis in the option, but they have twisted the MCQ. So answer for this question will become elevated HbA2. So that is indirectly telling you like this is electrophoresis. But same question, like in future, they will ask you. So if this is the option given, this is the best. High performance liquid chromatography. Remember, for any hemoglobin chain defect. So just I'm writing here for chain defect. So where we see chain defect. So chain defect we can see in thalassemia. Chain defect we can see in sickle cell anemia. So in all this a chain problem, the best test sequence, the best test will be HPLC followed by electrophoresis. Moving to next one. A 60-year-old male. So 60 year, first hint always is age. So age is the hint. Known hypertensive for 5 years. So patient is hypertensive for 5 years. So whenever like you see the case, something you should automatically, like in medicine, you will not get a simple like one-liner type of question. So you have to create something in your brain. 5-year hypertensive, so automatically understand this patient will be having LVH, left ventricular hypertrophy. So most patient who are having hypertension, they develop LVH later on. Was recently started on ACE inhibitors, so he's taking drugs. Now you should think about ACE inhibitor side effect. It could be, it can. So we have to remember side effect will be like it can cause dry cough. It can cause angioedema. It can cause hyperkalemia. So these things should be always in your head when you solve a clinical case. Then they're asking what is the electrolyte abnormality that you want to follow up. And next clinical is simple. So answer is in front of you. So once you try to solve question like this, you will automatically get the answer. So what we are checking? ACE inhibitor can cause, even ARBs can cause mild to moderate hyperkalemia. And sometimes when they are causing a lot of hyperkalemia, what we have to add diuretics to remove this. But don't add potassium spared diuretics. So answer for the question will be hyperkalemia. So what I want from you is like medicine question is always simple. Just it's a bigger question. Just when you are reading it, try to make the differential diagnosis in your brain. So let us see the next one. A 50-year-old male patient came to OPD with complaint of cough. So cough is the hint. Shortness of breath. Weight loss. This is the bigger hint. So X-ray is given. So now understand you have to read the question as well as X-ray finding. So in X-ray, I can say, suppose you know nothing about X-ray, so you can see like aspergilloma, it is like a fungal ball. You can see single patch. So that is not a single patch. You can see multiple white fluffy opacity. So when you see multiple white fluffy opacity, these are nothing. These are and even you can see some like hilar LED in between. So it will be like a white fluffy opacity. Weight loss is the hint given. Now we need to correlate aspergilloma and later stages can cause ABP, allergic bronchopulmonary aspergillosis. That can cause weight loss. Now see, cough is not the hint I will say, because cough you can see in any respiratory condition. So aspergilloma will not have history of weight loss first thing, and just will not have these multiple nodules. Allergic bronchopulmonary aspergillosis can have weight loss because it is seen in immunocompromised patients. So, but again, you can see like there will be no multiple these white fluffy opacity. And if you see mesothelioma, it's a tumor of pleura. So whenever you see a tumor of pleura, means it's a tumor of pleural cells. Pleural cells, what they do, they will secrete more pleural fluid. So more pleural fluid means more mesothelial cells means more pleural fluid. So it will present with pleural effusion. So it will not present with white opacity. You will see here pleural effusion. So this is the case of METS. Because weight loss is there and you can see multiple white opacity, and these opacities are called cannonball appearance. These opacities, what we call them? We call them cannonball appearance. So this is very, very important. Clear? Okay, moving to next one. A patient came with symptom of hypercalcemia. So again, this is like only 2-3 skull X-ray images they ask in exam. So I have intentionally not put the image of multiple myeloma where you can see lytic bone lesion. So here you can see the skull. You can see some black and white spot in the skull. This type of skull, what we call a salt and pepper skull. Salt and pepper skull. So here patients having hypercalcemia, salt and pepper lesions. So what is the condition? So understand this. Hyperthyroid, thyroid is having no relation. Langer and cysticercosis can also have skull changes. Multiple sclerosis will not have, multiple myeloma will have. So understand this. You can see these salt and pepper skull and hypercalcemia. These are feature of hyperparathyroidism. So answer for this question will be A. So remember, sometimes they give you X-ray of like I have seen from in many attempts they have asked the question on lytic bone lesion. So this time this is in my expected list. This time they can ask you this question, right, related to salt and pepper skull. Important. Okay, this is like about side effects of OHA. So again, trending topic. This is 100% chance. Very, very important. Something which is like from related to this like OHA side effect, they will definitely ask an exam. So see, a type 2 diabetic patient started on treatment, complaint of frequent micturition, frequent urination, fever and burning micturition. So when you see this type of complaint, it means a patient is now having UTI or cystitis. So either it could be a UTI or it could be cystitis. Following drug is most likely responsible for these symptoms. So just I want to make a table here because they're asking this type of question. So here I'm writing OHA and side effect. So again, they will not ask you that question. They will just try to twist the question in form of clinical case. So what are the potential side effects you can see with OHA? So starting first with a biguanide. So biguanide, we have drugs like metformin, fenformin. So biguanide is basically a group. So we have drugs like metformin and fenformin. So metformin, fenformin, their side effect will be lactic acidosis. So for this reason, even fenformin is withdrawn from market. Then remember, a metformin is a drug which will not cause hypoglycemia. So that's a good advantage. But remember, lactic acidosis is also rare. Most common side effect, if you ask me, that will be GI upset. This is most common, especially in person, like when you start this drug. Then sometimes they will ask you like metformin, fenformin, they can also cause B12 deficiency. So these are the side effects which you need to remember for metformin. And they are also like, remember, you should decrease the dose when patient is having a low GFR. Coming to next one, so next group will be sulfonylureas. Sulfonylureas. So this is like again a class of drug which they ask in exam. So if you ask me side effect of sulfonylureas, the most common side effect you can see like they are different from metformin, like they can cause hypoglycemia. And most of the sulfonylureas, remember, they start with G. Like nowadays we use second generation like glimepiride, gliburide, glibenclamide, glipizide. One more thing I can say, metformin can cause weight loss and sulfonylureas can cause weight gain. Moving to a third class, which I'll say like this third and fourth class I'm writing together. So it's the class like we have a DPP4 inhibitor. DPP4 inhibitor, and we have a class called I can say GLP-1 analog, or GLP means glucagon like peptide. So DPP4 inhibitor and GLP analog, these are two drugs like where I can say all these drugs are gliptins, and here we have drugs like exenatide, sexenatide. So there is a assumable side effect like they have caused, I can say, MTC, medullary thyroid carcinoma. So this is like reported in some animal study. Then they can cause, I can say, these type of drug can lead to a damage to exocrine function of pancreas. So automatically they will cause pancreatitis. So these are the possible side effect of these two class of drugs. So I'm writing together third and fourth. Moving to next class of drug, which I'm writing, this will be class number fifth. So here, like we have drugs like group is called thiazolidinedione. Thiazolidinedione. So here we have drugs like rosiglitazone, pioglitazone. So in long term, they are supposed to cause bladder cancer. So there is some risk of bladder cancer. Moving to next one, we have like alpha glucosidase inhibitor. Alpha glucosidase inhibitor. So here we have drugs like acarbose, voglibose, miglitol. So these drugs, understand they can cause flatulence. They can cause osmotic diarrhea. And remember, in IBD patient, they are contraindicated. So you should not use this in patient with Crohn's disease or ulcerative colitis. And moving to the last class in my list, because these are the important class. So we have SGLT2 inhibitor. So these drugs, like this is again a potential MCQ here. These drugs can cause UTI. So that's why patient can develop burning micturition. So these patient can cause a side effect called euglycemic ketoacidosis. In the last year, I told you this thing. This euglycemic ketoacidosis is an expected question. Unfortunately, it could not came in your exam. But remember, recent UPSC exam, this exact question came. So euglycemic ketoacidosis, you will see with this drug. Then sometime it can cause pathological fracture. And it can also cause Fournier's gangrene on long-term use. So basically, like this is like a game changer drug. We have many advantage of this. Like we have drugs like anagliflozin, empagliflozin, dapagliflozin, and this is the future of diabetes in India. Very important drug. So again, now you can see like patients having UTIs. So if you see the drug will be dapagliflozin. Just remember one more thing they can ask you. These drugs are now approved to prevent heart failure even in non-diabetic patients. So this could be again a potential MCQ. Metformin, lactic acidosis, betel deficiency, exenatide, saxenatide. So these are basically your I can say GLP analog. Glipizide will be sulfonylureas. So again, to answer this question will be dapagliflozin. Moving to next one. Let's say this question. RTA victim means road traffic accident victim is brought with breathing difficulties. So maybe patient met some accident. Now let's see. Following is noted. Following JVP finding is most likely. So what it is given, BP is 80/57. Do you think it's a normal BP? No. So how we label this? We label this as hypotension. So till now there is no hint in the question. Now you can see pulse is feeble. Pulse is feeble means there is a weak pulse because patient BP is less. When BP is less, you cannot properly feel the pulse. So it's a weak pulse. JVP is elevated. JVP is elevated. So you can see like engorged neck veins. JVP is elevated. Heart sounds are muffled. When you write the word muffled, like, but remember nowadays examiners are smart. They don't write the word muffled means diminished. So muffled heart sound. Muffled heart sound. Raised JVP. And hypotension. So I know now things are hitting your brain. This is a triad. What triad we call? We call this as Bake's triad. And Bake's triad is seen where? Bake's triad is seen in a patient with cardiac tamponade. In cardiac tamponade, remember a mnemonic which I am writing in front of you in big letters. So that mnemonic is pay tax. Pay tax, which means pericarditis will have a prominent Y descent. Tamponade will have a prominent X descent. So tamponade will have X descent. Now let us see the option. Absent X and Y descent, no. Prominent X and Y, both are prominent, no. Prominent X, you can see tamponade will have prominent X. Any one will be prominent. So you can see prominent X and absent Y. So answer will be prominent X. And remember, so just let me write this here. Cardiac tamponade will have a prominent X descent and constructive pericarditis. Constructive pericarditis will have a prominent Y descent. This one, sumatriptan can be given in which of the following diagnosed with migraines. So sumatriptan is actually DOC of migraine in acute attack. And can you tell me what is the drug of choice in prophylaxis? Yes, come on, it is propranolol. So they're asking you who can get out of this list? A 35-year-old female presenting with positive UPT. UPT is urine pregnancy test. So actually saying sumatriptan, these triptans, these are contraindicated in pregnancy. So you cannot give this to pregnant patient. 47-year-old male with history of cerebrovascular disease means stroke. Again, triptans are contraindicated in stroke patient because they increase the chances of stroke. A 52-year-old male with history of coronary artery disease means patient is having angina or MI. So remember, triptans are contraindicated in coronary artery disease and cerebrovascular disease. So when I read the question, I have ruled out 3 options. So let us, even like I don't have to read the 4th option, but let me read this. A 42-year-old female who has taken ergot alcohol in the past 1 week. Now see, most of the physicians in India, when they want to treat migraine, they start with triptans. But still, like I can say, in some villages, due to cost issue, triptan, like it cost, if you see, triptan costs on 50 rupees 1 tablet. That has been expensive. So 50 rupees a tablet in India, you cannot prescribe this tablet to all the people. Many people will not afford that tablet. So understand this thing. Ergot alkaloids, these are cheaper alternative. So suppose a person, a female, like no other history is given, who have taken ergot, there is no benefit, then definitely we have to start triptan. There is no other option. Is it clear? So remember, they can ask you like triptans. Remember, they are contraindicated in, I can say, a patient who's having cerebrovascular disease and coronary artery disease, and we should try to avoid this as much as possible in pregnant patients. So we will also not give this to pregnant patient. Now coming to next one, let us see. A patient present with left-sided facial paralysis and left-sided limb weakness for past 1 hour. What do you think now? 2 things should come into your brain. So there's hemiplegia, one-sided unilateral hemiplegia. So either it could be TIA or it could be stroke. Her blood pressure is 160. So BP is in a, I can say, normal range, little elevated, but it is considered normal. CT appears to be normal. What should be the next step in management? So just try to understand this. BP control is done when it is more than 220. So BP is almost 160. So there is no point of reducing the BP further. So just try to understand this. Whenever you are having a stroke patient, so we have 2 types of stroke, that is ischemic stroke and hemorrhagic stroke. So just try to understand this. Ischemic stroke, it is like here you have to use thrombolytic drugs. So whenever you are introducing thrombolytics, for example, we are using altiplase, so that we should use in less than 4.5 hours. So this 4.5 hours is something we call this window period. And hemorrhagic stroke, understand, if it is a small bleed, this will settle on its own. If it's a big bleed, suppose if it's a small bleed, so then we will do nothing. We will just observe the patient and do the symptomatic management. But if it's a big bleed, then we have to refer the patient to neurosurgery unit, and what they will plan for burr hole surgery and sometime like craniectomy. So that will be a case in surgery department. Now understand this here. We have a stroke protocol. As per the stroke protocol, understand, it could be TIA, it could be stroke. Now many of you are thinking like, sir, CT is normal, so it can be. It is TIA. But remember, TIA take time to resolve. So it take 24 hours. So maybe your patient's having TIA, right? And if you wait for a few hours and let's see like a patient is resolving or not. But in that case, you are missing this timeline. This timeline is 4.5 hours. Is it clear? So just try to understand this. I'm making a stroke protocol in front of you, and this is very, very important. Suppose a person is coming to you with stroke. A person is coming to you with stroke. So first test, stroke means how you will feel it's a stroke. So you can see like either there will be speech impairment, or so there will be speech problem, means patient will have a sudden mouth deviation, he cannot speak anything, or it could be hemiparesis. Straight away, the first test will be CT scan. So when you are doing a CT scan, in CT scan, what we can see? We can see like blood will look whitish. So that bleed, even calcium will look white. So you can see either it could be a white It could be a more dark or black. So understand this thing, when you see white, it means it's a bleed. So when it's a bleed, you understand like you have two options, either observation or you need to send the patient to neurosurgery department for surgery. But whenever it's a black, here you need to introduce thrombolytic drugs. Am I right? Thrombolytic drugs. So in bleed, what do we do? If it's a small bleed, observation, symptomatic treatment, or we have two options. Second option, if it's a big bleed, so then we will refer the patient to neurosurgery. They will do butthole surgery or open cranectomy. Now understand this thing. Sometime it happens, even in practice, many times it is seen, like CT can be like, we call this isodens or normal. CT can be normal. So understand? Thrombolytic drugs, whenever you are giving thrombolytic drugs, you need to give this in less than 4.5 hours. So window period is 4.5 hours. If you miss this time, so now our patient is already 1 hour late. So now we are left with 3.5 hours. It may be TIA, but we can't take the risk. If it is stroke, because we don't know it is stroke or TIA. If it is TIA, it will resolve. But if it is not TIA, then this will be irreversible damage. Patient will never reverse. So remember, as per stroke protocol, what current guideline says, you do a CT scan. If CT is normal, even if we are ruling out hemorrhage. Once hemorrhage is ruled out, do thrombolysis. Simple. So thrombolysis only when you will not do, whenever there is a bleed. If it's a no bleed, do thrombolysis, because you have to match that time. Always remember, in management of stroke, time is money. Clear? So this is again a good question. So let us see the option now. Nothing since CT was normal. No. Hemiplegia is there. Start on aspirin. Aspirin clopidogrel you will use, but later on. Intravenous thrombolysis. So again, what we'll do, we'll start with thrombolysis. Advice BP control, no. So answer is C. Moving to next one. Following type of non-Hodgkin lymphoma and its corresponding grade are correctly matched. Correctly matched, they're asking. Now say small lymphocytic lymphoma is high grade. Follicular lymphoma is intermediate grade. Diffuse large B-cell lymphoma is low grade. Burkitt lymphoma is high grade. Just try to understand this. Small lymphocytic lymphoma is a low grade tumor. It's a low grade tumor. Then follicular lymphoma. So just let me write here what I want to tell you first. So let me just write here. We have non-Hodgkin lymphoma. In non-Hodgkin lymphoma, we have different types of tumor. Out of this, remember, diffuse large B-cell lymphoma and Burkitt lymphoma. Diffuse large B-cell lymphoma and Burkitt lymphoma, these two tumor are considered high grade. And in fact, remember, Burkitt lymphoma is a very high grade tumor, and DLBCL is actually a complication of other non-Hodgkin lymphoma. So these two are always high grade tumor, and even like Burkitt lymphoma is kind of one of the fastest growing human tumor. And DLBCL is a complication, means follicular cell lymphoma, even I can say marginal zone lymphoma, mantle cell lymphoma. They have maltoma, hairy cell lymphoma. These all will convert into DLBCL. Even some leukemia like a CLL can also convert into DLBCL. So DLBCL is actually a complication. So when they want to choose the correct statement, to remember, DLBCL is a low grade, not incorrect. Burkitt lymphoma is high grade. Burkitt lymphoma is high grade. So this is the most correct option out of this. So Burkitt lymphoma, diffuse large B-cell lymphoma is low grade. It's very high grade. Even it's the highest grade. Follicular cell lymphoma, it is considered a low grade, low to intermediate. I can say small lymphocyte lymphoma is considered a low grade. So correct match statement will be Burkitt lymphoma. It's one of the highest grade human tumor. Other things they can ask you, like translocation for Burkitt lymphoma is translocation. Yes, come on, which one? 814. And in Burkitt lymphoma, you will see tingible body macrophage. That pattern is what we call this starry sky appearance. Starry sky appearance. Moving to next one. A 58-year-old female with granulomatous inflammation. So first hint in the MCQs, granulomatous inflammation. And Krebs on auscultation. So auscultation, there is a Krebs, means patient is having some sort of pulmonary edema. That's why you can see crepitations. With lymphadenopathy. Prurifusion following rash in the face. So this rash you can see. Now understand this thing. Many of you are thinking it is like SLE butterfly rash, but remember, if you see this rash, this is more depressed. SLE rash will be like more superficial. Now you can see SLE is more in young female. So if you see the question, you have to relate your pathology notes here. Out of the given option, lupus vulgaris is skin TB. So only this option B and C, these are the only example of granulomatous inflammation. SLE is not granulomatous. Scleroderma will not have this type of rash. Instead of this, like scleroderma patient will have multiple telangiectasia, microstomia, a shiny face, and then you can see like sclerodactyly absence of these folds in the back of finger. Now only these two are granulomatous inflammation, and because TB you will see I can say caseating granuloma. In sarcoidosis you will see non-caseating granuloma. Now seeing the question, granulomatous inflammation, then you can see Krebs, lymphadenopathy, pleural effusion. All these things you can see in both TB and sarcoidosis. Then why it is not TB? Because remember, skin TB will have only generally only skin manifestation. It is extrapulmonary TB, right? And this classical rash, what we can see here, this classical rash which is shown here, in a TB you will not see this rash. A skin TB, what we see like apple jelly nodules. This classical rash, what is shown in this image, is called lupus pernio. And lupus pernio is seen where? In a patient of sarcoidosis. And sarcoidosis is diagnosis of exclusion, remember. So again, sarcoidosis, although disease is very difficult to diagnose, but in patients are very rarely diagnosed in practice, but in MCQs it's a very common disease that they ask. Very, very important topic. Moving to next one. Following is not a reversible cause of dementia. Just understand the theory which I am giving you here. Suppose any dementia which is due to some deficiency or deficiency means that is reversible. So any deficiency, or I can say correctable cause. So dementia due to some deficiency or a correctable cause, that is reversible. But any dementia due to neurodegenerative disease, because in our brain what we have permanent cells. Once they are destroyed, they are destroyed. So in neurodegenerative disease, dementia is irreversible. So remember, example of neurodegenerative disease include Alzheimer's disease, Parkinson disease, dementia with Lewy body, Huntington disease. So these are neurodegenerative disease. So now let me read the question. Now see, vitamin B12 deficiency, can it cause dementia? Yes. Vitamin B12 deficiency can also produce a complication called SCCD, subacute combined degeneration of spinal cord. So this is like deficiency, so it is reversible. Normal pressure hydrocephalus. So sometimes we use shunting procedure to treat this. So again, this is a treatable cause, correctable cause. This can be reversible. Hypothyroidism, when you start levothyroxine or thioredoxin, this is reversed. So Lewy body dementia or DLB, dementia with Lewy body, this is neurodegenerative. It is reversible. Very, very important. A person bought 2 bottles of a liquor shop or of liquor from shop. Let me just edit the question. And later present with drowsiness, ataxia, blurry vision. So understand this. So what they are telling you like person, if I want to say this MCQ in Hindi, like patient ठेके से 2 बोतल दारू की लाया, उसके बाद ड्राउजी हो रहा है, अटैक्सिया हो रहा है, ब्लरी विजन है. तो शराब की बोतल ला रहा है, मीन्स अल्कोहल ला रहा है. So they're asking you simple pharmacology question. It's basically a pharmacology question that they're asking is, what is the antidote for alcohol toxicity, right? He is developing alcohol toxicity. For alcohol toxicity, what we use fomepizole. So let us see diazepam. Like remember here I am telling you diazepam is a drug. Diazepam, chlordiazepoxyl, lorazepam, these are the drugs we use in alcohol de-addiction. So initially when person want to quit, suppose he is chronically addicted to alcohol, his main problem will be when he is not getting alcohol, he cannot sleep. So that insomnia is developing. To calm the patient, first what you will give? You will give diazepam. So first test what we give diazepam, or like in practice we prefer chlordiazepoxide because it is even longer acting. If it is like LFT range, in that case we will prefer lorazepam and oxazepam. So these are the drugs we use in addiction process. Naloxone is a drug which is an antidote for opioid toxicity. It is opioid antagonist. But remember, naloxone will also have anti-craving action. So there are certain drugs. So just let me write this. First you will give diazepam. So these drugs are used in de-addiction process initially because patient will have insomnia where he is not getting alcohol. Now understand? Naloxone. Then we have drugs like ondansetron. Topiramate. Topiramate is basically an anti-epileptic drug. Acamprosate. So this is a mnemonic called NOTA. So understand, this NOTA means naloxone. These are the drugs which will have anti-craving effect in alcohol. So although just I can say naloxone, remember it's also an antidote of opioid toxicity. Ondansetron is an antiemetic drug. Topiramate is an anti-epileptic drug. So these are the drugs which have anti-craving action. These are anti-craving in case of alcohol addiction. Now coming to flumazenil, it is a drug that we use in benzodiazepine toxicity. So it is the drug of choice for benzodiazepine toxicity. Even they can ask you like drugs like Z drugs like zaleplon, zopiclone, zolpidem. In that case also we give same flumazenil. So the answer for this question will be fomepizole. Moving to next one, loading dose of alteplase in 80 kg person. So alteplase is thrombolytic drug. So we assume like our patient is having stroke. So in stroke case, what we use 0.9 mg. Now you are telling sir, this type of question will not ask in FMG exam. They can ask. So that's very, very important. Remember, now they are asking you dosing. So 0.9 mg per kg is a dose that we use. So 80 kg. So 0.9 mg means if you see 80 kg per person, so 0.9 into 80. How much it is? 72, right? Now 72 is not given the option. It is not given the option. To understand this, how we treat a patient of ischemic stroke. So the dose is 0.9 mg per kg. In this dose, we give 10% as bolus. So 10% we give as bolus and 90% we give as infusion over 1 hour. So 10% as bolus. So 72 means if you see like 10% of this will be 7.2, that is close to 8 mg, right? So exact dose is 0.9 mg suppose, but like this is the reference from Harrison. But if you see like in some other medicine textbook, they write like this 1 mg per kg. So when they ask you like 1 mg per kg, this will straight away become 80, right? So 10% of 80 will be 8 mg. So this will be the loading dose, means bolus dose. Am I clear? So this is like an important MCQ that they ask in exam. Moving to next one. Curb 65 score. So understand this. Curb 65 score stand for C stand for confusion. U stand for BUN, blood urea nitrogen, more than 7 millimole per liter. R stand for respiratory rate, which is more than 30 per minute. B stand for BP. BP means SBP, systolic blood pressure, that is less than 90. Means patient is having hypotension, and 65 or more is age of the patient. So C for confusion is the score. Yes, except question they're asking. Systolic BP less than 100? No, it should be less than 90. So this is the answer. Respiratory more than 30? Yes, it is in the score. It's a part of score. BUN more than 7, yes, it's a part of score. So blood pressure should be less than 90. It's clear? Now this is like a very decent MCQ they have asked. They have given all the correct options, almost correct. But remember, 90 is the lower limit which you have to remember. So these are component of CAR-65 score. And I told you like in previous question, we use the score. Along with this, we have one more score called PSI index, pneumonia severity index. So PSI index and CAR-65 score. These two scores we use to assess the severity of pneumonia. So these two scores we use to assess the severity of pneumonia. Moving to next one. Most common type of lung cancer in light smokers. Light smoker who smoke less, or we consider them light smoker or non-smoker. So in this case, remember, most common cancer will be adenocarcinoma. So just let me write it here. Adenocarcinoma is more common in non-smoker or light smoker, or I can say females. It is most common cancer in females. Small cell carcinoma is not a common one, and most common cancer in male or in heavy smoker. Heavy smoker, this will be squamous, and in India. And I can say adenocarcinoma is most common in USA. Small cell carcinoma is having highest association with smoking, but it is not a common one. So remember, the answer will be large cell is very, very, very rare. It is diagnosis of exclusion. Small cell, also called as short cell lung cancer, it will have even though a maximum paraneoplastic symptom, but it is not again a common. And squamous cell is more common in heavy smokers. So answer will be C. Moving to next one. An old woman, like this is something which I am seeing from 5 years. Every alternate attempt of FMGE exam, you will see this question. So that's why I added this question. An older woman present with persistent productive cough and clubbing. Auscultation, wheeze and crackles are present. So wheeze, when they are present, it means it is some sort of obstruction, means it's a case of OPD, obstructive pulmonary disease. No history of fever, there is no fever. So what is the most specific investigation to confirm the diagnosis, right? So just try to understand this. There is persistent productive cough. So when I talk about obstructive pulmonary disease, so there are 4 options. First option is bronchial asthma. Then what we have conditions like, I can say, chronic bronchitis. We have emphysema. And we have bronchiectasis. One more condition is bronchiolitis, which is extremely rare, that is seen in children. So again, here you can see old woman. Now see, productive cough and clubbing. So when I see the word productive cough, you can see in all these 4 conditions. In emphysema, you will see productive cough is unlikely, because emphysema patient, they will have more shortness of breath. Cough is now settled. So emphysema is unlikely. Now see, bronchitis and emphysema both will not have clubbing. Asthma will not have clubbing. So only option what we left with, bronchiectasis, and investigation of choice will be HRCT. So they have asked this one-liner form sometime as a clinical case. So remember, investigation of choice for bronchiectasis will be HRCT. This is again like last year NEET PG question, a fresh question came in exam. Following types of kidney stone are produced by laxative abuse. So like some people, they take a lot of Ayurvedic laxative, and even like our allopathic laxative can also cause this. So uric acid stone, remember, this is something which is having association with some drugs. Struvite stone, staghorn stone, or proteus stone. So this is due to proteus. Calcium oxalate is most common. So understand this, laxative will produce ammonium urate stone. Very, very important. Moving to next one. A 1-year-old male child is having heart rate of 40. Pediatrics and overlap with medicine. Heart rate of 40. BP 90/60. Potassium level 6.5. What's next? Means you can see like a normal level of potassium. Normal level of potassium will be 3.525. So this is a normal value of potassium. Now you can see it's a clear-cut case of, because if you see the option, So like BP is 90-60, that's quite okay, although heart rate is a bit lower side. So you can see it's a case of hyperkalemia. So hyperkalemia, so it is like an impending cardiac arrest which can happen to patient. So here potassium value is given 6.5, so diagnosis will be hyperkalemia. And once this value reach more than 7, like patient can have cardiac arrest. So what we can use? Can we use ipratropium? Ipratropium we don't use, we can use salbutamol to treat hyperkalemia. Salbutamol or beta agonist or albuterol, what they'll do, they'll try to send potassium back into cells. So ipratropium we don't use. And salbutamol here will have an added advantage. This will increase heart rate as well, but that is not even the option. Do you think it's a shock case? Adrenaline we give in shock patient. Soda bicarb we give to patient of acidosis. There are no signs of acidosis. So in hyperkalemia, remember the drug of choice. Drug of choice will be calcium gluconate. When calcium gluconate is not available, alternative will be calcium chloride. Remember, calcium carbonate is calcium tablet. Here, so we can use calcium gluconate, which is not given the option. So ultimately, what we have to use calcium chloride. So it's a case of hyperkalemia, and what we are using calcium chloride. Moving to next one, a 30-year-old man presents with sudden onset of headache. Young male, headache, palpitation, profuse sweating, PhD, palpitation, headache, diaphoresis means sweating. He had several such episodes in the past. During these episodes, his BP is found to be high, and 24-hour urinary metanephrine is elevated. So now you will tell me, sir, this is an easy question. Why have I added this? Because from here they'll ask you many MCQs. So diagnosis is clear. It's a case of pheochromocytoma. So what I want to confirm here is pheochromocytoma. Understand, it's a tumor of adrenal medulla. So they ask you always a question on the diagnosis part of this topic, pheochromocytoma. So pheochromocytoma term you will use whenever it's a tumor in the medulla. Whenever the tumor is in the medulla, it's a tumor of chromaffin cells. So sometimes we use the term chromaphinoma. But if it is located outside the adrenal gland, we use the term paraganglioma. We use the term paraganglioma whenever it is extra-adrenal. So in adrenal medulla, we call this pheochromocytoma. Now understand, suppose whatsoever it is it pheochromocytoma, paraganglioma, first test that you will use, this will be 24-hour urinary metanephrine. So urinary metanephrine level. So this is the test that we do for screening. So don't make a mistake here, because I am telling you this thing. This is very, very important MCQ. First test, screening test, 24 urinary metanephrine. To confirm what you will do, we will do plasma metanephrine. To confirm, you will do plasma metanephrine. So this is the, I can say, investigation of choice. Confirmation or confirmatory test. So here, like you can see, urinary metanephrine is elevated. But I want to go in more detail. Suppose when you want to localize the tumor. When you want to localize the tumor, so you have to go for a CT abdomen. But sometimes it is not detected in CT abdomen. So we need to do an MRI scan, MRI abdomen. This question asked already, like what is radiological investigation? So remember, radiological investigation of choice will be MRI scan. Is it clear? So radiological investigation will be MRI scan. Now fourth, understand this, remember, if tumor is very small, if it is like I can say when size, if size is less than 1.5 centimeter, so sometime it is not detected in I can say MRI scan, then we have to do a DOTA TATE scan. This is the expected MCQ, DOTA TATE scan. Right. Alternative to DOTA TATE scan, which is like again it can be as an exam, but that is not a test we routinely do in practice. But this is people's favorite, that is MIBG scan. So understand this thing, if tumor size is small, we can go for DOTA TATE scan or MIBG scan. So preferred is rotated scan, but sometimes question they out is some outdated topics. So this MIBG scan or rotated scan, this could be asked in exam. I think many of the time they have asked about MIBG scan. So I can say possible MCQ here is rotated scan. Is it clear? So let's see once again. First test, urinary meta-interference, confirmatory plasma meta-interference. Radiological investigation of choice or investigation of choice to localize the tumor, MRI. If tumor is very small, if it is very small or located outside the abdomen, so in that case, what we do? In that case, we'll do rotated scan. Right? What else we can do? MIBG. MIBG is meta-iodobenzoguanidine scan. Moving to our last question. Following is likely to be seen in a patient diagnosed with acute MI. So understand. In normal healthy people, LDH2 values are more than LDH1. In MI, you will see LDH1 value more than LDH2. Right? So generally, when I see this ratio means 1:2 ratio. In MI, let me write about MI only. LDH1 is to LDH2 ratio. So LDH1 is more. So actually, the exact is more than 0.9. But we consider this as 1. But it is actually 0.9. But 0.9 is not given, so I am omitting it out. I am just actual value is 0.9. So let me write it 1. So let us see the option first. One option I am removing because 4 is not at all a part. Right? So what you will see in a patient with MI? LDH1 is to LDH2 ratio less than 1. LDH value is more now, so it cannot be less than 1. LDH1 is to LDH2 ratio more than 1. It's the correct answer. LDH2 is to 1 ratio more than 1. So that is actually normal. So this is like normal people and this is the case of MI. Right? What about option 1? LDH1 is to LDH2 less than 1. They are confusing you in increased degree. Again, it's normal. Right? This will be normal. So remember, just one line remember, you have to remember in MI, LDH2. In MI, LDH1 is more than LDH2. We call this as flipping of LDH. For this, we use a term, that term is flipping of LDH. And if you see the ratio value will be more than 0.1 or exact value is 0.9. So I hope we have discussed these topics which are like important. Basically, the point was you should be aware of the topics which are frequently tested. So we have discussed stroke, we have discussed anemia, we have discussed the topic of lymphoma, we have discussed MI. Then we have discussed some other MCQs which are important, pheochromocytoma. So these are the important topics which you need to see once before exam. Thank you so much. Remember, be confident. You only need 50%. And you are the future of this country. So you can do it. Wish you all the best. Bye-bye.